It's a wonderful feeling to have a partner.
Discover NVNA and Hospice.
Again, you're transitioning from one place to another. We want to make sure that goes smoothly.
Right.
You get home, you have the right medications. We talk pretty in depth about what are they going to need for this safe transition. What do they need clinically, functionally? What can we give them at home to keep them safe at home and to ultimately prevent a readmission to the hospital? We really want to help them succeed at home. And I've been asked by Diane, the social worker here at the hospital, to come in and talk with you guys about your mom's upcoming discharge. I would meet with that social worker. I would then screen the patient's chart very thoroughly to find out what happened to them clinically, what brought them to the hospital, and what brought them to the rehab. And then I would proceed to meet with the patient and typically their family as well, to let them know what our role would be and find out what kind of family involvement there is and what their expectations are for this person to be at home. We do bone density screenings, we come out and do blood pressure clinics, we do blood sugar screenings, offering a wealth of information to people, gearing mostly towards seniors. We have certified wound care nurses, ostomy nurses. Our chronic disease management program is just fantastic for people who, again, have these chronic diseases that they're trying to deal with, but maybe with a little bit of assistance and help, and maybe the form of a support group could help these people. We also have a tremendous hospice program. So our nurses go out and screen patients. Maybe they have certain diagnoses that fall into that category. Hi, I'm Noreen Cataldo. When I come and meet with them, I'll explain to them about the difference of certified home care or private home care. I let them know what they're eligible for through their Medicare benefit or their private insurance if they had Blue Cross or Tufts. I can let them know the types of services they're entitled to. I can also let them know about that private division, which is a supplement. So a lot of people will start off with our certified home care and then maybe transition over to that private. So I can educate them a little bit about that. We have wonderful people who are so happy to go out and meet with the families and talk about their private services. We like to reinforce to the family that we're going to do our best, but I have to reinforce to them also that where it's a time limited. We don't come for blocks of hours, 4 to 6 hours. That's a misconception in the community. Some families believe that, oh, I'm getting visiting nurses, so somebody will be here for the 8 hours that I'm gone. So I think there's a lot of education around that piece, and maybe the family might decide, geez, I'm going to need to have some extra help, and then hire some additional support for those hours. It's very common, very, very common. So, we work with that client. A lot of them have neighbors, friends, church friends that come and help them. And we offer, again, we try to optimize support from within the agency and within the community. People really, really and truly want to age in place. They really do. They, against all odds, they just want to try it. And sometimes people need that trial. They need to know, I've tried one last time, to go home, give it my best shot effort. What we do in those situations, we front load it. In the initial period of going maybe from an acute care hospital to home, we might have the nurse come in daily. We might have the physical therapy come in 3 days consecutively to really try to make the most ideal situation and then figure out what we can wean out and what they might still need. And is this reality-based? Can this really work? Are the odds totally against this person being safe at home?